the question that was posed was, what is your choice? And my answer is neoadjuvant chemoradiation in non-small cell lung cancer. Now, if someone were to make the statement that neoadjuvant chemotherapy, that means chemotherapy alone, followed by surgery, is the gold standard for N2 lung cancer, the scenario where we use it most common, my answer would be this. So let us see why. And the reason is because the evidence that you have for neoadjuvant chemotherapy followed by surgery, the kind of regimen after which the whole world is fascinated and many people are following, is this is the kind of evidence that we have for this. So we had two trials published in 1990s, and trial number 1, trial number 2, each had around 60 odd patients, 30 in each arm. That is what surgery versus preoperative chemotherapy followed by surgery. And that is what kind of convinced us that, okay, this is the way to go forward. And we started following neoadjuvant chemotherapy followed by surgery. Cut to more recent trials, URTC study. So the question is, after neoadjuvant chemotherapy, first question that I'm tackling is, after neoadjuvant chemotherapy, if we do surgery versus if we do radiation, are the outcomes different? And this URT study, published in 2007, very famous study, told us that there is no overall survival difference for stage 3 in these two approaches. Not only this study, there have been 2 or 3 more randomized studies, including the RTOG 8901 MRC study, which have told that after chemotherapy, if you randomize to radiation versus surgery, there is hardly any difference. So that is regarding issue number 1. The second thing is that radical chemoradiation has established itself fully and firmly in stage 3 lung cancer. And we have data from Operin JCO 2010, extensive study, data from 6 trials, telling us of the excellent outcomes with concomitant chemoradiation, radical chemoradiation in such a setting. So where is the need to look left and right now? Now, still there may be some clinicians and some people who might be still interested. No, I want to do something in the neoadjuvant scenario. And then these trials were published, in Lancet, very reputed journal, and Manish also discussed these trials. Yes, no survival benefit, but definitely statistically significant pathological response rates, higher pathological CR rates after neoadjuvant chemoradiation compared to neoadjuvant chemotherapy alone. Not only one trial, trial after trial, telling you the same thing. Yes, no survival benefit, but definitely higher and much higher pathological complete response rates and partial response rates after induction chemoradiation compared to chemotherapy alone. That brings us to another very important trial of Kathy Albane. And this trial again, I'm talking about this trial again because this trial is a very important trial, and it told us that in case, yes, you are very keen, then this approach of chemoradiation followed by surgery can actually lead to better outcomes, especially in patients where you're talking about lobectomies. Yes, you should be cautionary for pneumonectomies, but as far as lobectomies are concerned, if you're giving an approach of concomitant chemoradiation followed by surgery, it is going to be a very appropriate approach for this group of patients. Talk about a real life scenario now. Open the NCCN guidelines. What do the guidelines say in the discussion part? And I have highlighted this. In patients with N2 disease, 50% of the NCCN member institutions use preoperative chemoradiotherapy, and only other 50% are using preoperative chemotherapy alone. So in the real life scenario also, a huge, almost 50% of the esteemed institutions are using preoperative chemoradiotherapy. Just in case you want to use something in the preoperative thing, I think chemoradiotherapy should be a very important choice. And if, in case you feel that, okay, I'll give neoadjuvant chemotherapy followed by surgery and I can escape radiation, you cannot escape radiation. You have data from umpteen trials, including the Anita trial, which is telling you that in N2 disease, radiation is a must in terms of reducing local recurrence rates, in terms of improving overall survival rates. There is no way you cannot include radiation in this group of patients. So it has to be given. Now, the sequence we can talk about, my preferred sequence, give it upfront. And this is actually,
Anusheel,
yes.
Anusheel, you'll have about a minute more.
I'll take half a minute maybe. So this is my proposed paradigm. Begin with neoadjuvant chemoradiation, not with neoadjuvant chemotherapy. And then probably in many groups of patients, row number 1, 2, 3, you don't need surgery because neoadjuvant chemoradiation becomes the decider for the prognosis. In a very small subgroup of patients, you can take the patients for surgery. And with advanced radiation modalities at your hand, including 4D treatments, less toxicities, I think you have to consider the fact that toxicities are going to be less. You have MR-guided radiotherapy, 4D radiotherapy, and therefore it is a very, very safe approach now. So respected jury, colleagues, friends, for lung cancer, for the patients not operable upfront, chemoradiation is the way forward. However, if you want to give something neoadjuvant, it should be neoadjuvant chemoradiation. So either neoadjuvant chemoradiation or definitive chemoradiation is the way forward. But giving neoadjuvant chemotherapy alone in lung cancer, I feel is unscientific, unwarranted, illogical. And respected jury, colleagues, friends, I think the case is crystal clear. With that, I rest my argument. Thank you.